So first thing we're going to do this morning is have Dr. Dianna Cody from University of Texas MD Anderson Cancer Center and one of the coordinators of our DOSE Summit. She's going to come up and walk us through homework and solutions. Do you need any slides or anything?
No.
Okay. Can you get that? There we go. There you go. You have 27 minutes.
Okay. Hopefully everybody was just looking at the slides that was talking about the evaluation process and how to get CME credit and all that stuff. I'm hoping that there is a comment part to the evaluation. One of the things we really would like to hear from you is what should we do next? Do we need to repeat this? Do we need to maybe make an annual event? Do we want to shorten it and just make focus on new things, new applications, new techniques? We're looking for feedback on where to go from here. So if you could think about that and add that to the comment section of the evaluation, or just send us email, something, we would really appreciate that, because we could use some help in figuring out where to go from here. Okay, so how many people actually looked at the homework? I'll be darned. For real. How many people wrote stuff down? Yeah, that's what I thought. Okay, so I'm just going to go through the questions that should have been covered, so the speakers that have already been on, and give you some ideas. The printed solutions will be available with your lunch. So as you do your grab-and-go lunch and head out, grab one of these on your way. We're going to put them in piles all over the place so we won't all pile up in one corner. So the first question had to do with flank pain and ER. And basically, we're seeing a whole lot of these type of scans in this particular emergency room, and we're worried about repeated flank CT exams on a big number of patients. And so what would be some of the approaches to remedying that situation? Dr. Brink recommends to provide educational opportunities for the ER physicians regarding dose. I happen to believe none of us can know too much about this, and hopefully the ER docs would be hungry for that kind of information. Might want to suggest that imaging tests ordered by trainees require the approval of somebody more senior. That might help reduce some of those extra CT exams. You may want to encourage the use of other techniques like ultrasound and plain radiography in place of flank pain for those who've had previous CT exams. Those ultrasound is a little bit more operator dependent than CT, but it's probably faster. You can actually get a quicker answer if you know what you're doing. Another approach would be to explore the implementation of a fancier computer order entry screen that provides just not necessarily the appropriateness criteria, but just how many exams these patients have had in the past. Our radiologists at MD Anderson are starting to ask those very same things. Can't we quickly look at the history of the CT exams that any patient has had? That information should be available on our radiation information system. And we're actually redesigning that tool right now, and we're hoping to add CT dose as part of the database. But a lot of folks have not really worried about the dose part, but just count the exams. I've seen that a number of times. When you get up to a magic number, say 5 exams in the last year, some little red flags go up and say, are you sure you really want to do this? You want to rethink this? You want to talk to a radiologist before you move forward? And then his last suggestion is to consider implementing a decision support system, such as the one I was just talking about, the appropriateness criteria. Okay, one of Jim Kofler's homework questions has to do with, this was one actually that I wrote that he used because it's more appropriate for him. But this is the kind of thing we run into all the time. We're not getting quite the image quality we want. It's usually the liver. The liver tends to be the most challenging part of the body, as far as I can tell, in our CT exams. And we can't really get confident images of the liver in our large patients. But we're already worried about radiation dose, and we don't really want to go there by increasing the technique. What are some other things we could do that would actually improve the image quality without any dose burden at all? And there's actually a number of them. We can look at a softer recon algorithm, for one thing. We can double check that the detector configuration is appropriate. Sometimes you can improve image quality just by being a little bit more clever about the way the settings are implemented. We can be sure that we have the most dose-efficient detector configuration. So you want to look and make sure that we're not using one, a thinner beam, for example, when a thicker beam might do as good a job at a lower dose, in which case you could actually bump up the technique a little bit to keep it constant. You may want to explore making the images a little thicker. For larger patients, this is actually a pretty good option. You can look into automatic exposure control options. Now, this actually probably would result in an increase in dose, but it might be appropriate for your larger patients. And if there is an iterative recon mode available on your scanner, definitely want to take a look at that. I think all the vendors are coming out with that type of an approach here pretty soon, and so that's something you're going to want to look into in the future. They are not cheap. They usually also require upgrades of computers and consoles, but my administrator, our division of radiology is 1,000 people, so it's really a big one. And our top-level administrator is now getting very concerned about the radiation dose in CT. And some of our medical center competition, although it's not really competition, is starting to market low-dose CT in Houston. And so she's getting real sensitive about this and wants to be able to say, honestly and sincerely with a straight face, that we're doing everything we can to limit our radiation dose to our patients, especially because as a cancer center, one of our main missions is prevention of cancer. So she's getting a lot more sensitive about that, and we're starting to, we've always been the data hog. The number of images that we make is way more than everybody else, so we're always the hog in terms of needing computer space and needing redundant archive and all that stuff. But we're also starting to be the budget hog because we want all of these dose reduction options, and they don't come cheap. And your capital budget's only this big, and CT wants to use this much. So it'll be very, very interesting to see how that plays out because of all the press about radiation dose in CT. Okay, Jim Kofler's second question. We have 30 or 40 basic protocols, and we're a little worried that they could be better, that there's some inconsistencies across the scanners, that we maybe aren't using them in an optimal fashion. But darn, I'm really busy, and I don't have a spare moment. How do we address this kind of a problem? And this is pretty real world, because there are a lot of places where I think there is a level of concern, and there is also no time, because everybody's running short-staffed. So his suggestion is to first get support from the department leadership. This is actually an important thing to address, which is going to mean resources. So somebody has to be able to say this is important enough to devote some time and some people to. And then you have to actually come up with the people, select those that would be both most interested and have the expertise that you need. Usually this is a combination of a technical person, like a medical physicist, a technologist who understands the scanner, and a radiologist who understands the goal of the imaging task. In my particular institution, each section has one person who's really sort of the protocol guru. So there isn't a single radiologist involved. There's like a half a dozen radiologists. But the technologist group and the medical physicist group are quite consistent. At that point, these people have to come together and have a plan, determine some course of action. We would recommend you start with the most common protocols, your bread and butter protocols, the ones that get used the most often. That's where you're going to have your biggest impact. That's the low-hanging fruit. Those are the ones you really want to tackle first. And then you really need to go through the protocols line by line, parameter by parameter. And some of these more complicated ones, I was thinking there could easily be 100 parameters. Well, we heard yesterday there could be 55 parameters for a single pass, which is way more than I thought. So there can be a lot of little nitty-gritty details to double check and hammer down. But I'll tell you, I've had a number of cases where it seems like there's 100 or 200 parameters in a protocol set, and you lose track of one stupid little number, and you start hearing screaming radiologists. So it really is worth looking through all of those little bitty numbers and coming to convergence and figuring out what you're going to do. This process does get easier as you go along. You learn a lot after you've done the first couple, and so while the first few may seem like pulling teeth and torture nightmare, it gets easier, and you actually learn, and things kind of smooth along, and it gets a lot faster as you move forward. And he also suggests that this type of an approach may be useful in other modalities, that this may not just be a CT problem, that there may be room for improvement in some of the other imaging modalities as well. Okay, next question. We want to reduce the scan time for an exam, but we don't want to increase the dose. So how would you approach that? Well, for sure, one of the things you want to look at is decreasing the tube rotation time. Just the rotation time, if it's at 1 second, look at kind of driving that down, see what your options are there. Another approach might be increasing the pitch, making the table move a little faster. Now, both of those things are going to require a compensatory increase in MA, and you may have an X-ray tube that has a limited capacity, and this may or may not be feasible. But that's something that you can look at in terms of decreasing the scan time. Another good option is to look at wider beam width. I know on a bunch of our protocols, particularly the neuro ones, they seem to be using the narrower beam width, and I've never quite understood why that is. But if it's not a problem, it's not a problem. But it is one of the ways to decrease your scan time if you can increase that beam width. Now, there may be downstream effects to that. You may be limiting the thinnest image that you can actually create, and so you want to keep an eye on that. But increasing the beam width is a good option for decreasing the scan time. Again, thicker images, softer recon algorithm, and you can watch the doses that are displayed as you start making some of these changes. So you want to keep an eye on that CTDI vol number and see, as you start messing with some of these parameters, how that changes so that you're in about the same ballpark that you started out with. The next question was, who was most likely the person who posed that question? Was it the medical physicist, the technologist, or the physician? And truly, this is across the board. Everybody, I think, associated with CT is starting to get worried about this. And so the answer is yes. All of those. Any of those. Okay, so Mike McNitt-Gray's problem had to do with, we're doing a routine chest, for example, and we get this very annoying warning that the tube is too hot already and we can't actually do the exam as planned. The technologist is under the gun, patient's ready to go, and we've got to decide right now what to do. And this actually happens a lot, and the technologist should have already an action plan on how to deal with this. And it may depend on what kind of an exam it is. It might not. It might be something that's sort of across the board. So some options to consider would be trying the automatic exposure control. Especially if it's a small patient, you might not need the level of MA that's been programmed in. If it's a larger patient, that may or may not help you too much. You can try a lower pitch. This is actually going to slow the exam down a little bit, but it will allow you to drop the MA, and that's what the tube wants you to do, is somehow decrease that MA. You can use a slightly slower rotation time. Again, this will let you drop the MA a little bit. Now, both those options are going to slow the whole exam down. So if this is a chest and it's someone who's quite ill, that may not work very well because they may not be able to hold their breath through the whole thing. But these are options to consider. You want to make sure that your detector configuration is optimal. Again, widest beam width, but you can still get the thinnest image you need, and that it's the most dose efficient of your options there. I'll tell you, not related to this homework question, we've had a couple of instances lately where we've had patients completely prepped. This is usually not just IV, but also rectal contrast and tubes and things hanging out of them. And then all of a sudden the scanner says, I need a tube warm-up. And you can't do anything until you warm up my tube. And the patient's on the table. And shoot, what do you do then? The technologist is, unglued. Well, we've had this happen enough, and it seems to be a scanner glitch because it's always in areas that are really freakishly busy, and there's no way the scanner was idle for 2 hours and long enough for the tube to cool down. So it's one of these weird things. It's happened probably twice in the last 7 or 8 years. But it happened just a couple of weeks ago. And the tech was on the ball and remembered what happened last time and actually draped an apron over the patient, pulled the patient out of the gantry, and ran the tube warm-up so that we could actually move on with the exam. Now, the reason that was actually a good idea and the best thing to do was the last time it happened, that's what they did. And then we actually put some detectors in there to see what happens when you do a tube warm-up. And on RGE scanners, at least the one that we checked 5 or 6 years ago, the aperture doesn't open during a tube warm-up. So it's like leakage current. So it's like there's no exposure, really. We couldn't actually measure anything. So this particular patient that's happened on a couple of weeks ago had enough exams that he knew something weird happened. And he actually called back a week later to find out what that was, and how much extra whatever did I get during that strange thing that happened. But we could say with a lot of confidence that it was actually absolutely not an issue. That we actually want to go back and make sure on the newer scanners that that's also what happens. But that's something you might run into at some point. It's not something we want to do as a general practice. It's definitely not something we encourage, but if you get stuck that way, that's a good way to deal with it. Okay, next homework problem. We're going to do routine abdomen on a larger patient. And the tech notices that, darn, the CTDI valve number that's showing up is really high, especially compared to the last patient who was kind of small. And this really worries me, and I'm not sure what to do. How do I approach that? Well, in this case, we need to understand that CTDI vol is not patient dose. This is dose to our phantoms. This is really scanner output. And that for larger patients, a higher CTDI vol is probably quite appropriate, and that we shouldn't get all freaked out and worried about that. We want to actually look at the image quality that we get from our larger patients with these particular settings that we have and make sure that they're acceptable. And if they're acceptable, we might actually be in a position to drive them down a little bit. One of the good ways to approach dose optimization is to start somewhere and then start cranking things back until radiologists scream and say, okay, that's too far, and come back one step. But if you don't actually try that, you don't really know how low can you go. And it's very much a radiologist acceptance criteria that you kind of have to go through until they say, I can't find what I'm looking for. I can't see this well enough to have confidence in what I'm trying to accomplish. Okay, next homework problem is from Piccicello, and here you're entering your client's office, and the manager walks by and says, oh, hey, since you're here doing your annual survey, I'm assuming you're also going to check all our protocols because, I'm hearing that's a pretty hot topic these days, and you might as well do that while you're here. And so how would you respond to something like that? Well, hopefully, the first thing you do is explain the scope of your survey. These are the things that I'm contracted to do. And you'll see that reviewing all your CT protocols is not on that list. It actually happens to be a very time-consuming thing that I really can't do alone. This is sort of a team approach. If you want me to do that, I'd be happy to talk to you about that. And we would need to come up with a plan and a team and actually a timeline, because this isn't something that can be done adequately in 5 minutes. This is more of a longer-term project. And so it would require a lot more discussion and a lot more planning. Okay, and that's it, because the next homework question is mine, and I haven't given my talk yet. So we're going to stop there and move on with the schedule. And we actually are a little ahead of time, so that's good. So we might actually finish a little early. Yes? Oh, yeah, since we have a few minutes, good idea. Are there any questions about the stuff we've covered so far on this homework stuff? Everybody got all the right answers? This was exactly what you had in mind, what you were thinking? Okay. Well, I guess we're all...
No, stall for a minute.
No, stall for a minute. Okay. Why?
So we can load your talk before Jim gets on.
Oh. Okay.
Or go through another homework. We have time for one more.
All right. Go right ahead. Let's see. What else we have here? Okay. Did anybody have any answers to those problems that weren't posed? Did you have anything that was more clever than what we came up with? Hello? Anybody there? We need more coffee. Here we go.
Pull down. It's usually because they protocol the entire case, and it's seeing everything, the chest, the abdomen, the pelvis. And I've had that situation several times, and I'll say, no, just stop. Just protocol the chest, do the chest, and then just wait a few minutes, or let the tube cool off during the interval between the time, and then start all again. And usually we get enough time in between the chest to start the abdomen, and the tube cools off enough. It just sees too much when you try to protocol all of it at once, and then it's anticipating that, and it, for whatever reason, often will give us that problem. So break it up. That's what I usually tell them. And if you have to wait for the pelvis, wait for the pelvis, because it doesn't really matter. The timing of the contrast isn't nearly as important.
Thank you very much. Everybody hear that? No? Okay. So very often the scanner will be looking at all of the groups or all of the series all at once. And even though there's delays that are built in, you can actually stretch out a lot of those delays. And so if you sort of break that up a little bit and have the scanner only pay attention to one set of images at a time, you can often sort of baby it through the exam and not be stuck waiting. Go right ahead.
Yeah, just one quick comment on the one where you're on the question regarding equalizing the protocols across the different systems within your hospital. Is another factor to consider is if you have scanners from different manufacturers, you can't just equalize the MA or the MAS across those scanners, because you have to try to equalize image quality, and that becomes a little trickier. So there's an extra level of equalization that has to be done across different scanning manufacturers.
That's definitely true, and a really good point.
We're stalling, actually, because we're ahead of time. We're going to regret that later. I'd like to actually see some show of hands, because we, besides the feedback, we are wondering whether or not, if you went home, tell your colleagues about this, even though things are on the web, and you can show them your PDFs and talk about it, do you think there's still plenty of people that would want to come? Because we had to turn plenty of people away from this. Show of hands, how many think we should repeat this again in a short time window? Wow. Okay. Well, there's that answer. How many, do you have a comment to add to that?
Actually, I found out about it from our physicists.
Okay.
As an X-ray tech, they didn't come out to do any of our resources. So, you know, if you are doing RT and real time, so there's nothing like that.
Okay.
Just the techs are the ones that are listening to it.
I agree. In fact, the techs were probably the group that got locked out, if you will, because since it sold out so quick, most techs would have to go show it to somebody, get some approval. Will you send me to this? So we actually, I'm going to track down Mike Kudlis afterwards and talk about, can we run something like this at an ASRT meeting? Oh, we're going on tour, guys. Okay. Yeah, comment.
In terms of equalization across the facility, even if they have all the same manufacturer, but say a facility has a handful of scanners, one 4-slice, a 16-slice, a couple older 64s, and a couple newer 64s, should we really be recommending blanket protocols, or should we be trying to take advantage of the capabilities of the newer, better technology?
Definitely, with our protocols, I was saying we do move whatever we can on the newer technology in, but we're still, if a 5 millimeter is the appropriate with about this much noise, we try to make that constant. So that exam gives that, but the newer technology will have either lower dose or is that
Faster
what you're
rotation
asking?
time, more detectors,
Yep.
Wider beam width, that kind of thing.
Yep, we will go, and so hence it'll have shorter scan time, shorter breath hold, and all that good stuff, but the image quality we'll try to make as common as possible. Okay.
I want to go back to your question.
Oh.
Sorry, I had another answer for that.
Okay.
We have just that situation, and we actually only allow certain exams to be done on the older scanners. And it's a very small set, and it's a shrinking set, because they are just not able to do the quality exams that we can get out of the 64s and the 16s. So you may need to sort of adjust your patient flow for the older scanners and not expect everything that you can get out of the other ones.
Short question. We're almost. Sorry, Bob. We're going to stop with Ken.
I'll catch you later. It takes a little time.